There's no excuse why a charge nurse in the ICU has 3 patients. Did you hear about the case of the nurse that gave NaturaLyte instead of GoLytely to a patient that ended up in the patient's demise? Now, I am not sure if TikTok is like YouTube and bans certain words like KILL, so I will say things like demise and clock out instead of those words. I recently went live on my YouTube channel with Nurse Adrian and Nurse Scott. If you want to check out the full video and our thoughts there from the panel, the link is on my profile page on TikTok. But there was an ICU nurse and she was charge nurse that day. Not only was she charge nurse, but she had 3 patients that she had to take care of. Charge nurses should not have to take care of any patients because they have so many administrative responsibilities on their plate. In this video, I will discuss the chain of events that led to this mistake, but I will also discuss what you could do as a nurse to protect yourself. This video, I am not bashing this nurse. I understand that it's easier from an outsider's perspective to weigh in. I don't know what she was going through that day, but there are things that you could do to help prevent medical errors. A dialysis team left dialysis liquid behind on the ICU floor, and it could have potentially been there for up to 3 days. I understand that every hospital is different. So if you are a dialysis nurse, make sure you label everything clearly. If you have to, write with a Sharpie, dialysis liquid. Preferably don't leave anything behind because if your hospital is different and you do leave things behind, or they do dialysis on the unit and they don't bring a team in, make sure you label everything clearly. Write on that jug with a Sharpie, dialysis, not for PO consumption. Now, as a safety precaution, if you're a nurse, you know that we have to scan meds. So nurses have to scan barcodes on patients' wristbands. You scan the wristband and then you scan the medication, and if check, then everything is aligned. And then, so once they scan the medication, then they administer. So in this case, the dialysis liquid, which was thought to be the colonoscopy prep medication, wouldn't scan. So the nurse called the hospital pharmacy at about 5:35 p.m. and informed them that the jug would not scan. Now in the article, they go on to say that instead of the pharmacist coming on the floor, that they didn't bother to check, blah, blah, blah. Personally, I never have had a pharmacist leave their station because we did not have a pharmacist on our floor. I've never had a pharmacist leave our station to come and verify something. If anything, I go to the pharmacy. I've gone to the pharmacy myself if I needed something or if they weren't answering or whatever, right? Again, I understand pharmacists are very busy and they probably didn't think anything of it, that it wasn't scanning. They probably thought the barcode was faulty, whatever. And remember, ultimately the burden, unfortunately, lies on the nurse eventually, right? We are that last frontier for the patient. I urge you that if something is not scanning, get a second pair of eyes on it. Ask a colleague, hey, this medication is not scanning. Can you just double check and make sure I'm giving the right medication? Our minds will play tricks on us. Sometimes, for example, when you're proofreading an essay, if you're reading it to yourself, you think everything sounds great. When you read it out loud, you realize you missed the word the, for example, or you didn't capitalize a certain thing. So our minds can play tricks on us. When people are highly stressed, their frontal lobe, which is where our decision-making capabilities come from, often gets compromised. So instead of thinking and making logical decisions in these high-stress situations where nurses are overwhelmed, they turn more into fight or flight mode, the reptilian brain, where we're not even thinking clearly. So then the pharmacy sent a label to the ICU floor through a tube system, and the nurse must have scanned that barcode and she scanned the medication. She additionally wrote in her notes that the patient was unable to tolerate the liquid. Please, okay, when I used to pull meds from a Pyxis, and granted, she probably didn't even pull this from a Pyxis. Again, we don't know all of the details, but if you're pulling meds from a Pyxis, take your tough book or whatever you call it, your computer, compare it to the MAR, do 3 checks even before you get to the patient, right? I would take my laptop, I would go to the Pyxis, I would pull the med, I read the label, compare it to the MAR, compare it to what I just pulled out. And I'm checking okay, this, and again, I probably look crazy to my colleagues. Let's say I'm pulling lisinopril, I'm checking on the computer, lisinopril, this many milligrams. Yes, that's what I have here that I need to be pulling. So the nurse even wrote that the patient was unable to tolerate the liquid. If a patient, listen to your patients. Listen to your patients. A lot of times being a nurse, that you could get burned out, you can get jaded. I've seen so many videos of nurses either like bashing patients or calling patients needy or clingy, that one patient that's always calling, right? But put yourself in their shoes, right? I was in the hospital about a year ago and I had an awful experience where the nurse never left the call light near me. So I literally, I had just had COVID and I was going into like tachycardia, almost SVT. My extremities got stiff. I couldn't move. It was very frightening. No call light, nobody would come. And I could hear the nurses laughing and saying, who's calling and who's yelling? Like, so put yourself, if you've been a nurse for this long and you dislike patients to the point where you're jaded and you don't listen to them and you make fun of them, then you need to move to another unit, you need to move to another area of nursing, or you just need to get out of nursing. I'm not saying that this is the situation in this circumstance, but so in the letter to the nurse, the nursing board did voice concern that she had not visually double checked the medications label before administering it. What can you do as a nurse? Don't rely just on technology. Use your eyes, use your brain, use your logic, use your common sense. This says this, but this doesn't match. She was a charge nurse and she had 3 patients, so she was probably overwhelmed, not thinking clearly. But check your labels. Always check your labels. What does the MAR say? What does your label say? Does it match? Does the dosage match? Does everything match? And the author of this article had asked others to weigh in. So it says, while technology is used to help prevent mistakes, it can lead to a level of over-reliance and complacency, both Malucci and Jenkins said. And do not just rely on medication. There was a situation where another nurse on my unit was precepting a nurse, a new graduate nurse, and the patient kept asking for Ativan, and the Pyxis kept dispensing it. And let's say the order was for Ativan every 6 hours. But the nurse kept going like every 2 hours, and she kept dispensing it, and giving it to the patient, When her preceptor finally caught the error, she was like, what are you doing? The MAR says every 6 hours. And she's like, oh, well, I mean, the Pyxis kept giving it to me, so I thought it was okay to give. And it's like, use your brain, read the MAR. Just because a machine does something doesn't mean it's okay. This is the letter from the nursing board. That the letter states that 3 nurses had been pulled from the ICU that shift to work on another unit. When the patient who ultimately died was transferred to the hospital, she took him on as a 3rd patient. And again, there's no excuse for a charge nurse. I'm not just blaming this nurse, right? There's no excuse why a charge nurse in the ICU has 3 patients. First of all, ICU should maybe only have 1 to 2, right? That's the way it used to be, but now with the nursing shortage, they're getting up to 3 patients. That's inexcusable. And I will give you a few statistics in a little bit about how mortality increases for each additional patient that a nurse has. So Malucci goes on to say that there's nothing like the human mind to evaluate the state of circumstances when you're about to do something that's risky for a patient. And what I'm seeing now is, again, this was an ICU nurse, so ICU nurses deal with extremely ill, high acuity patients, so their level of knowledge is top tier, right? But I do know that there are new grads being accepted into ICU programs. I know when I personally worked, and there were baby nurses, we were still baby nurses, and they were asking us to be charge nurses. Like back in the old days, even before my time, because I'm not a spring chicken, but even before my time, charge nurses had some experience under their belt, right? Perhaps this person had a lot of experience. I don't know. We don't know the details of her experience, how long she's been in the ICU, but if you may want to consider, before going into the ICU, getting some med-surg experience, because going from no experience, going from nursing school to all of a sudden you're in ICU, that's a lot to take on. It is a lot to take on. I know students that have done it because I used to teach for 6 years. I know students that have done it, they've been able to do it, but it's difficult, and they were very stressed and very overwhelmed. If you notice on your unit that they're making charge nurses take patients, then you may just want to refuse to be charge nurse. Say, no, I will not be a charge nurse unless I have no patients, right? If we all start advocating for ourselves, then this profession can make headway. I have seen, I will say it again, this is a female-dominated profession, and we are not our own best advocates. We have this martyr syndrome. One of my previous students, Ileana, she's on TikTok too, Nurse Ileana, she was saying how she had just worked she had just worked like 3 12s. She was asked to stay later than the shift that she worked, more than 12 hours. And when she said no, another nurse shamed her and was like, oh, you're one of those? No, what do you mean I'm one of those? You mean I'm one of those nurses that sets boundaries and sets limits? We all need to be one of those nurses. We need to stop allowing toxicity in our profession and call that being a team player. So nursing staffing levels directly impact patient outcomes. The main reason why I left bedside was staffing issues. Main reason why I left. And I wrote papers when I was getting my master's degree in nursing education. I did a master's degree in nursing education, went back to school for family nurse practitioner, and I'm may or may not go back to school now for psych NP. So nursing staffing levels directly impact patient outcomes. I would write papers about this topic till I was blue in the face. I would take it to my managers, but it falls on deaf ears. The public needs to get outraged. This is not a nursing issue. This is an everybody issue, because when you, a patient, land in the hospital and your nurse is taking care of too many patients, your life is in jeopardy. Nursing staffing levels directly impact patient outcomes. For instance, intensive care unit nurses who are usually assigned 1 critical patient may now be caring for 3 due to staffing shortages, increasing the chance that patients miss care or that medical errors occur. This was written in 2021, and look at what has happened. Oh, surprise, a lethal medical error has occurred. It also can increase the chance that nurses feel overwhelmed, which can lead to burnout, and the cycle of staffing shortages continues, right? People want to talk the answer to this nursing shortage is to improve working conditions for nurses. There's students that I have taught after a year, after 2 years, they message me, they're like, this is not what I thought, I wanna get out. They come to me venting, they come to me sad, overwhelmed, burned out, because we educated them, but the system is failing them. The system is failing them. They go into this bright-eyed and bushy-tailed, idealistic, wanting to help, heal, take care of patients, but they're unable to do that because we literally are running around like a chicken with our head cut off on a never-ending treadmill of infinite tasks that we have to complete. And in between that, we're asked to be critical thinkers to make sure that nothing happens. But how can we make sure that nothing happens to our patients? How can we be checking EKG strips and all these things, fluids, and when there's an infinite amount of tasks that seem insurmountable to complete and we are not given the help that we need? You know, when I was a nurse, they just kept giving us more and more and more. Now it's very commonplace that the nurse draws the patient's labs. When I was a nurse, we had phlebotomists. And then we had what they would call environmental services, take out the linens and take out the trash for the patient. And every job is important in the hospital. I'm not downplaying the fact that environmental services is below us. My mom came from Colombia. She worked as a housekeeper. I respect people that clean, that do all sorts of these professions. But why is it that environmental services complained that they didn't have enough time to clean rooms in between patients? So do you know what they did? They start telling the nurses at the end of our shifts that we had to take out the patient trash and we had to take out the patient linens. Are you kidding me? When environmental services, their job is to clean. So why are we adding more things to nurses, but you're not taking anything away from us? You're not, okay, we're gonna take away 1 patient and you're expected to do everything. We'll give you 4 patients so you can take out the linens and the trash. And then on top of that, they got rid of phlebotomists, and then they said, okay, now nurses have to do all the lab draws for patients. They keep giving us more and more, and they keep giving us more patients, and something's got to give. We're literally crumbling under the pressure of everything that they give us. So the British Medical Journal published a study that said patient to nurse staffing ratios on medical surgical units range from 4.2 to 7.6. Now, I could tell you, when I was on a med tele floor, and if I had 4 patients, it was paradise on earth. I felt like I could have done that forever. If I had 4 patients on a med tele unit, I would have never left bedside. But it was usually 6 to 7 patients that we were getting. After adjusting for hospital and patient characteristics, The odds of 30-day mortality for each patient increased by 16%. I'll say that again. For each patient, each additional patient that a nurse has, a patient's mortality, the risk of death, increases by 16%. The odds of staying in the hospital a day longer at all intervals increased by 5% for each additional patient in the nurse's workload. If hospitals staffed at a 4-to-1 ratio during the 1-year study period, more than 1,595 deaths would have been avoided, and hospitals would have collectively saved over $117 million. 1,595 deaths would have been avoided, and hospitals would have saved $117 million. Hospitals administrators will often quote lack of money. We just don't have money to hire more nurses to bring down the ratio. BS. If you can afford to hire travel nurses during this COVID pandemic, figure it out. You can afford it, you choose not to. Figure it out. We're talking about, 1,595 deaths. That's a number. That's people's parents. That's a mom. That's a father. That's a brother. That's a son. That's a child. If you're watching this, please share with your nurses, but share with everybody in general. The only way change is going to happen is if patients become outraged, because at the end of the day, this all comes down to greed. And if we all come together, not just nurses, and advocate for better ratios, and if patients stop going to a hospital because they know that those ratios are abysmal, and they say, oh, I'm not going there, they give their nurses 7 patients, then hospitals will have no other option than to actually implement ratios. And I'm not saying ratios is the end all and be all and everything will be perfectly happy, kumbaya, if that happens, but it's a starting point, right? We can't just stick our hands in the sand and be cynical and not, I get so many people that are like, ratios isn't everything. Duh. But we have to start somewhere, and ratios is a great place to start. So things have to change. This cannot be allowed to continue. Hospital administrators, figure out your staffing levels. You can do it, figure it out. You have the budget. Stop constructing new buildings and pour money into the buildings you already have. Thank you so much for watching. Make sure that you share, make sure that you like, subscribe, follow if you're on TikTok or wherever I post this. Fight the good fight. I'm very passionate about this. We need improved staffing ratios. It does save lives.